Okay, so if you're wrapping up on the quiz, wrap up. Otherwise, we'll kickstart the session with Tom Hickman-Casey, who's our resident clinical fellow at Eastbourne and Brighton. He'll be talking about PEDS, squints, and genetic syndromes today. And if you've got any questions, Razor and myself will be in the background. So we're happy to do a bit of digging if you've got any perplexing topics. Over to you, Tom.
Okay, thanks, Yaro. So yeah, as you said, this is going to be sort of pediatrics. It's mainly about squints, this talk, and a few genetic syndromes as well. So that's all about us. So hopefully by the end of the session, you'll be able to recognize what the common squints are and how we investigate to diagnose these squints and differentiate between them, and a little bit about the treatment that we use for the different types. Also going to talk about some of the differentials for some common conditions that affect newborns and young children as well, and some other pediatric conditions that you should be aware of. So hopefully you've all done the pre-test, pre-talk quiz. So to start off, squints and strabismus. So these two words are interchangeable. They mean the same thing. It's not sort of what the layman says. A squint isn't sort of scrunching up your eyes. Ophthalmologists use the word squint to describe a malalignment of the two eyes. And it can be sort of broadly split into two different types of squint. So you have your tropias or your manifest squint. So these are obvious and they're always present. And the other type is your phorias, which are your latent squint, which aren't necessarily always seen at rest. So your eyes can be straight facing normally. So your tropias, yeah, they're always there. And the phorias can be detected when you dissociate between the eyes. So you use an alternative cover-uncover test, and I'll explain what that is in a few slides. We can also split squints into concomitant squints. So this is where the squint, the deviation of the eyes is the same in all directions of gaze, whereas in concomitant squints, the angle, the magnitude of the gaze of the squints changes with the position of gaze. So this is quite important, especially in children, where they're not going to give you such a good history. They don't sort of, things aren't as easy to elicit. And you might notice that children sort of adopt a malalignment of their head posture to compensate for this. So they might not complain of anything. It might not be obvious, but they tilt their head to sort of compensate for the squint that they have. And this is very important because by doing this, they advance the amblyopia. So this is when one of your eyes, the visual pathway is affected and you lose your visual acuity in the eye, which is deviated, which has the squint, because the brain retrains itself just to focus on the good eye. So I've got a slide here. So amblyopia, this is what the layman would call a lazy eye, and it's very, very common. About 2% of the population have it. And it's the most common cause of unilateral decrease in visual acuity in children. So as I said before, it's a developmental dysfunction in the visual pathway from the eye to the visual cortex. So lots of causes for these. So it can include sort of cataracts, congenital cataracts, refractive errors, but it can also be the function of the eye can be absolutely normal. So an ophthalmologist looks at it, there's nothing sort of to assess within the eye itself. So people say that the patient sees nothing and the ophthalmologist sees nothing too, because the function of the eye is absolutely normal, but it's a developmental dysfunction in the visual pathway. So it's worrying because if it's left uncorrected, the brain will start to favor the normal eye and need to sort of neglect, in a sense, of the affected eye and decrease in visual acuity. So it needs to be picked up quite early in young children, and then you can sort of correct it. So what we tend to do is we use occlusion therapy. So we cover the good eye with the patch to try and encourage the visual pathway to develop better in the eye which is affected. So in the UK, what we do is we sort of put a cover over the eye. But obviously with children, if you're covering the good eye, the adherence is pretty poor, and children don't sort of tend to tolerate it very well. So you can use sort of pharmacological drops, so atropine, to help adherence to that sort of pharmacological occlusion therapy, so that sort of encourages the child to use the poorer eye to develop a better visual pathway. So I'm just going to give a bit of more some terminology about squints. So orthoptists are allied health professionals, and this is really their area of expertise. So lots of ophthalmologists rely quite heavily on their orthoptists, and they say that the ophthalmologist is only as good as their orthoptist with regards to these squints, and they're quite sort of involved in screening of young children, and they pick up and manage quite a lot of this stuff themselves. Binocular single vision. So this is your ability to have two separate images detected in your eyes and form one image that you observe, and this helps you to good binocular depth perception, stereopsis, and it's not fully developed when you're born. It takes a few months to be fully developed, but if it doesn't develop properly, this causes esotropia. So I'll talk a bit more about that in a moment. But essentially, any reduced vision in one eye can interrupt your binocular single vision and result in a strabismus, in a squint. So lots of different causes for a dysfunction in this. And the last term that I want to just be aware of is the ACA ratio. So this is your accommodative convergence to accommodation ratio. So don't want to go too much into detail about this, but if you think if you're looking at something which is nearby to you, your something's beeping, I don't know. Essentially, so if you're thinking of something nearby to you, your eyes do two things to help you focus on it. So you accommodate, so that's the altering the curvature of the lens, and you converge. So your eyes move inwards together to focus on this, on the object. So accommodative convergence is measured in prism diopters, and accommodation is measured in diopters. So I don't think you need to know a huge amount about this, but just to know that if you have a change in this ratio, that can lead to different squints. And a normal ratio is about between 3 and 5. So I think it's just something to be aware of. And I'd mention it a bit later, just to learn that a change in this ratio can lead to certain types of the squints. So the main type of squint are tropias. So these are manifest strabismus, so it's always present. Very common, 5 to 8% of the population have this, and it's where one of the eyes is not directed towards a fixation point. So it's diagnosed with a single cover test. So sometimes it might be very obvious. So if you look at the diagram on the right, these are pretty barn door, you'll be able to notice this. But if it's a little bit more subtle, you can diagnose it with a single cover test. So what you do here is you occlude one of the eyes, and you're looking at the non-occluded eye to look for a shift in fixation. So the eye will move. If there's no movement, that's orthotropia. So there's no malalignment, it's fine. But if there is a shift in the eye, if you're covering one eye, you're looking at the other eye, if there's a shift in movement, that's atropia. So there's 4 different types. We have esotropia, so that's where the eye is diverted nasally, and when you're covering the other eye, you'll notice the eye moves outwards with the single cover test. Exotropia is the opposite, so the eye is normally deviated laterally, and when you cover the opposite eye, it will move in nasally. And then you've got your hypertropia, where it's deviated superiorly, and your hypotropia, where the eye is deviated inferiorly. And so we can measure the angle as to how far the tropia is with prism cover testing. So prisms are, I've got a slide on it later, it's sort of a topic in itself, but just to sort of help you understand, there's different strengths of prisms, and essentially you're covering one eye and you're increasing the strength or the power of the prism until you are getting no deviation or no shift in fixation. And that's how you notice how strong or what the angle of the strabismus is. Okay, so just a bit more detail on esotropia. So this is your most common childhood squint in the UK, and it's got a strong family history to this. So you might get lots of sort of siblings or parents having the same problem. And it can be split into accommodative and non-accommodative. So non-accommodative is more common, and it's normally develops early on. So children sort of in the first 6 months of life, you'll be able to spot this, and it's very large angle. And it can be associated with horizontal nystagmus. So it's important, the eyes have normal refraction. There's no refractive error with non-accommodative esotropia. So you can't cure it with glasses. The management is surgical for this. Whereas accommodative esotropia, this is associated with hypermetropia. So long-sighted children can often have accommodative esotropia, and it usually presents this a bit later. And there's 3 main types of this so it's fully accommodative. So that's where you can correct it completely with glasses. Partially accommodative, so you can use glasses to correct it to a degree, but it still requires some treatments such as sort of occlusion therapy, or you can have convergence excess. So this is going back to the ACA ratio. So it's a high ratio in this, and you require bifocal glasses and also some surgery. So for bifocal glasses for children, they're normally quite big. You have both lenses are quite large. So if you think for an old person, they can just have the little bits in the back of their glasses for reading, for near vision, whereas children, it needs to be a lot bigger, because otherwise their adherence is worse. So you need to sort of be a bit more forceful with the size of the bifocals, so that they are more prone to actually using them. So the second type is exotropia. So as opposed to esotropia, this is associated with myopia. So short-sighted children get this, and it can either be constant or intermittent. So intermittent exotropia is more common. And so when we say intermittent, we mean that it's not always there, and it can be brought on by stressful situations, or when the patient is tired or ill, you start to notice it more, or even daydreaming as well. And another thing you see with this is patients who have excessive blinking as well. So we split the intermittent exotropia into distance and near. So true distance exotropia is made worse when you're looking at a distance, which has a normal ACA ratio, whereas simulated distance exotropia is made worse with distance, but has a high ACA ratio. And then obviously opposite to that is the near, which is worse for near vision. And that constant exotropia is much more easier to see. It's larger, and the options, the management here is all surgical. So for strabismus, so basically you do 2 things. If you consider the extraocular muscles like a pulley. We do two things. We resection, where we're shortening the muscle, or there's recession, which is loosening the muscle. So the thing to both eyes here, so that can be quite confusing, especially for parents, that they might see their child has got one eye with a squint, but we tend to operate on both eyes. So so for example, if you've got an exotropia, you'll do a bilateral lateral rectus recession and a medial rectus resection to correct misalignment. That's just to sort of to compensate for both eyes, to give yourself more of a window to maneuver. So we operate on both of them, and that's just a picture. You just make a sort of incision to be able to access the muscles, and you can take a bit of it out. So I've included a slide on prisms. So I don't want to get bogged down on this because it's a massive topic on itself, and I don't think that you need to know a huge amount of it for this talk, and I don't want to be giving you too much to worry about, and I don't want to feed you with wrong information. But I think you just need to be aware that prisms can be used a lot in ophthalmology, and can be used diagnostically and therapeutically. And so prisms sort of refract light, they bend light towards the base of the prism. Prisms more are used for adults with squints. The reason being is that when you're a child, your eye is still growing, still developing, and the power of the prism will be needing to be changed quite frequently. So it's not really a viable option for children with developing eyes, because they're quite expensive, and it's wouldn't be appropriate to be constantly changing this for children growing. But when you're prescribing a prism, they should be split between the two eyes, and the powers of the prisms are split evenly between your two eyes. And the base of the prism points away from the deviation. So I've got an example. If you've got a esotropic eye, the base is pointed temporally, okay, and the apex nasally. And the prisms should be pointing in opposite directions for each eye. Okay, but yeah, I wouldn't get too bogged down on this, but it's just an appreciation that this is something that we can use. So going on to extraocular muscles, I'm sure you're all aware of this. We have 6 in total, 4 recti and 2 oblique muscles. Most of them are all innervated by the 3rd cranial nerve, but you have your SO4, your superior oblique, is innervated by the 4th cranial nerve, and your LR6 is your lateral rectus, innervated by the 6th cranial nerve. So each muscle has primary, secondary, and also some of them have a tertiary function. So the secondary functions, actually, they're not the main direction that the eye moves, but they are part of the movement that it aids, but it's just not the most important action of it. 2 things I think be worth noting are the medial rectus has the closest insert to the limbus, whereas the superior rectus is further from the limbus. So I think it's just learn those two, just the 2 of those, because it's quite an easy exam question to ask. But I think it's also worth learning the primary and the secondary functions as well. So a few definitions about the extraocular muscles. So antagonist-agonist muscles, these muscles in the same eye move in different directions. So your right medial rectus and your right lateral rectus, they sort of oppose each other, where you've got your synergist muscles and then the same eye, but help move the eye in the same direction. So for example, your right inferior rectus and your right superior oblique. So this is why you need to know the secondary functions, so that you can know which muscles are synergist muscles. And yoke muscles, this is in different eyes that cause movement in the same direction. Okay, so I think that's hopefully quite clear. And then we have two laws here that, so yoke muscles involved in a particular direction of gaze receive equal and simultaneous flow of innervations. So I think that's probably quite obvious that you need the movements are the same for each eye. And Sherrington's law is similar to that in the sense that an increase in innervation of one muscle is accompanied by a decrease in innervation of its antagonist. Okay. So then moving on to heterophoria, your phorias. So this is your latent squints. So when you're looking straight ahead, you might not notice any deviation at all here. Whereas when you're using an alternating cover test or a cover uncover test, this is when these become apparent. So if you've got a phoria, you'd have a normal cover test. So the last test I talked about, that would be appear normal with a phoria. Whereas, with a alternating cover test, so what you do here is you occlude one eye for 1 or 2 seconds and quickly remove the cover to restore the binocular vision. So as opposed to the previous cover test, you're looking at the previously occluded eye. So you're covering an eye, but you're looking for, when you remove the cover, that you're looking at that eye for any movement. So if you have a phoria here, your eye will shift back to looking straight ahead. So in this diagram here, you can see you've got the covered eye here, but this is so when you dissociate and you cover the eye will move inwards. And when you move, so for an esophoria, the eye is moved inwards when you're covering it up. As soon as you move this cover, the eye will move to realign itself in the center. And that's an esophoria. So inward deviation of the eye, and then when you remove the cover, it will move laterally. So likewise with your tropias, there's 4 types: eso in, exo out, hyper up, and hypo down. And this is very common and doesn't always need treatment. It can be managed with prisms or exercises to try and improve the squint. So a few syndromes here that are associated with this. So we have your Duane syndrome. So there's 3 types of this, but the type 1 is the most common, and this is retraction of the globe on adduction. So it's caused because your lateral rectus muscle is innervated by cranial nerve 3 rather than cranial nerve 6. So the medial rectus and the lateral rectus pull at the same time, and your eye sort of shifts back into the orbit. So it's associated with deafness and Goldenhar syndrome. Goldenhar syndrome is a congenital defect, which is of incomplete development of your ear, your nose, your soft palate. And so that's it could be an exam question. It's just linked. The 2 syndromes are linked. Whereas Brown syndrome is also congenital syndrome. It can be after trauma. And this is a mechanical restriction of the superior oblique tendon. So this leads to limited elevation on adduction. So in this picture here, this child's right eye is the one that's affected. She can't look up and in. So this eye is fixed here, and it can't look up here. And patients can report sort of hearing a little click when they're trying to move the eye here. So with children, obviously we can't assess their vision as we do with adults with the Snellen chart. And depending on how old they are, we use different techniques to assess this. So with newborn children, obviously they're not going to recognize much at all. So we do quite sort of similar to what you do in the cranial nerve exam. This is called fix and follow. idea that you have to move the bright light or the toy or whatever you're using to assess this. You have to move it very slowly because children, the muscles aren't developed properly, and if you move it too quickly, they won't be able to adhere to the test. But you should try and do it with both eyes separately if possible. But obviously, things are much harder to assess when children are that young. For children a little bit older, they have a picture on a card and it's thicknesses of the lines in the picture. And so what you're assessing is you're just seeing if the child is looking at able to appreciate the picture. So are their eyes looking up or down? And that's how you can assess whether they're able to see the card. And each different thickness in the card correlates to a Snellen equivalent. So you have the child sort of sitting on the mother's knee, and you show these cards sort of 50 centimeters to a meter away, and you just have a look, see are they looking up or down, and if they're able to correctly identify where the picture is, then you can give it its Snellen equivalent. If the child's a bit older and they're verbal, they're able to answer questions, or they're able to appreciate things a bit more. Patients, they can be quite shy, so they don't always verbally answer, but you can give them a special another card, and they just map them. They can point to which object they're seeing. It's quite similar. You have just different cards with single black line drawings, and the patient just identifies which one they're looking at. And similarly, each picture has a Snellen equivalent, so you can document it. And then as patients get a bit older, if they're not quite able to tolerate a Snellen chart, the next thing is the Keeler crowded Logmar test, which is similar. It's just this is this one. Also, no, this is the K pictures, but yeah, it's similar, but it's just not quite a Snellen chart. So some pediatric conditions now. So this is the most common thing I'm sure that you're aware of, leukocoria. So this is your white pupil. So if you ever see this in a child, this is very alarming and requires an urgent referral to ophthalmology. Mainly being, so the most worrying and most sinister cause of this is a retinoblastoma. So this is the most common intraocular tumor of childhood, with the most sinister cause. It's malignant tumor, and it can be either hereditary, inherited autosomal dominantly, which often presents bilaterally, or sporadic. And this is caused because of a loss of function of the retinoblastoma tumor suppressor gene on chromosome 13. But it's very important to pick this up early because the survival rates are quite good if it's detected early. But this is your most worrying differential of a white pupil. Other causes of white pupil, so you have congenital cataracts. So these again can be idiopathic, but also there's hereditary aspect to it. It's also linked with rubella. So you can get the white pupil with dull red reflex, can also present with a squint because patients aren't able to see properly through this and they develop a squint with it, or nystagmus. So the treatment of this is obviously if they've got a very debilitating cataract, you want to do a lensectomy and remove the lens. But the same problem with the prisms, it's not as easy as just sort of with a fully developed eye and just replacing the lens, because with the eye, if a child is still developing, still growing, it's very difficult to put a lens in which is going to be suitable long term for a child. So you have a few options, including contact lenses, aphakic glasses. So these are these really thick milk bottle glasses, and you get a lens, real consensus as to which is the best, most appropriate treatment for this. It depends on the age that they're seen and what will be most appropriate for the child. So another cause of your white pupil is your retinopathy of prematurity. So this is particularly common in young or preterm babies and babies with low birth weight. So during development in utero, your retinal periphery develops quite late on. So if a patient is delivered, sort of a baby's delivered less than 30 weeks, the periphery of the retina is not fully developed properly, and if they develop this once they've been born, it can the neovascularization is not it's not the same as in utero, and it can sort of lead to sort of bleeding of these new vessels, and it can actually lead to a tractional retinal detachment. So that's where the vitreous membrane pulls the retina, and you don't see any tears or breaks in the retina, but it's because of tractional retinal detachment. So if you see on the picture here, this is your demarcation line. So this is where none of these vessels have been developed properly in utero. So the options for this are ablation and laser. So and so yeah, that's that. So Coloboma. So this is your keyhole pupil. So this presents at birth. Is a mutation gene, but it can so it can be asymptomatic, vision, reflex with this. If it's severe enough, they can't see properly through that eye, and similarly, this is more pronounced when the child is tired or unwell. So we need to strengthen the muscle here. So what we do is we and then we is diagnostic for that. You see other things such as a cloudy corner here, excessive tearing, that's quite a key feature of this, and photophobia. The management we require treatment on a newborn child. Think congenital glaucoma. So a couple of other infective conditions here. So this is taken from my other talk on infectious diseases, chlamydial conjunctivitis. So ophthalmia neonatorum. So this is conjunctivitis within the first 28 so you get these white follicles, a red eye, and a stringy discharge. So associated with that's all for adults, but the treatment for children is slightly different, and we manage it with erythromycin drops as opposed to azithromycin or doxycycline in an adult. The other cause of this is gonococcal conjunctivitis. So this is quite serious. Get a really bad infection, and it can cause corneal ulceration and perforation. So you get this really sort of horrible coexistent with chlamydia. So you need to sort of do a swab and stain and treat with IM or IV KEF. But so yeah, this is mother's STDs. So and with a higher transmission rate. So it's something to be aware of if a newborn with discharge from their eyes. Okay, so a benign tumor, it's normally superior nasally. Not this picture's not the norm, but it's essentially it grows within the first 6 months of life, and it's described as a strawberry birthmark, but it can cause problems in two ways. So one is sort of ptosis, that you're losing your visual access and you're not being able to see have a full visual field, but also these can grow quite rapidly. It can put pressure on the eye, causing distortion. So it can cause astigmatism and a refractive error. So, but as I said, they're benign, and majority don't get this big, and they don't need treatment. But if they do, the first line treatment is oral beta blockers. I'm not quite sure. So then just to finish off, I've got a few other conditions. So styes and chalazions, these are from the other talk. I'm sure you'll know about them, but they're very, very common in children. And I also mentioned, so congenital nasolacrimal duct obstruction. So this is your valve cancer is not sort of fully developed in young children. It's not opened fully. Sometimes it takes about a year or so to fully open. So you get children have excessive tearing and can have recurrent conjunctivitis because of this, because they're not flushing away the tears covering the eye. So if it doesn't open, you can sort of syringe it and stick a probe to sort of forcefully open the valve, and that will start allow drainage of tears. So you shouldn't have so many complications of conjunctivitis after that. Limbal dermoid. So this is what this picture is showing here. So it's a benign tumor, also associated with Goldenhar syndrome on the limbus of the eye. So that's what that one is. And then a dermoid cyst, again, is a non-tender immobile lump on the orbital rim. The issue with this is there's a risk of rupture, so you can surgically remove them if it's affecting, if you're worried about that. And then the last thing to mention is non-accidental injury. So often the ophthalmologist will be asked to sort of screen a patient if a patient's coming in with unexplained injuries. The reason for this is to assess for shaken baby syndrome, where you get retinal hemorrhages, which are associated with cerebral hemorrhages. But it's also important to note that obviously any sort of clotting condition is also differential. So this isn't the only cause of these, but ophthalmologists will be asked to review patients who your query NAI. And that's that. So I don't know if there's any questions.